Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to Relatable Rheumatology, From Stories to Studies, a podcast where we explore the personal experiences of people living with rheumatic diseases and the latest research evidence. Each episode invites a patient to share a question or concern that they encountered during their complex diagnosis and treatment journey to be addressed by our experts. We aim to bridge the gap between patient experience, research, and clinical practice by providing relevant and relatable information. This podcast is a co-production with HCP Live. I'm your host, Dr. Shilpa Venkatachalam, and I'm Director of Research Operations and Ethical Oversight of Patient-Centered Research at the Global Healthy Living Foundation. In this episode, we will be exploring how the lived experience of someone living with a disease condition like rheumatoid arthritis can systematically be documented via the use of what we call patient-reported outcome measures, or PROs. Joining us to explore this topic today are Dr. Susan Goodman, Professor of Clinical Medicine at Weill Cornell Medicine and Director of the Integrative Rheumatology and Orthopedics Center of Excellence. She is also Medical Chief and Research Director of the Combined Arthritis Program at the Hospital for Special Surgery. A very warm welcome to you, Dr. Goodman. I'm also joined today by Shelley Fritz, who is an educator and patient advocate who lives with rheumatoid arthritis and several comorbidities. Welcome to you too, Shelley. So, as we've been talking, patients may have very different goals from their physicians as they make treatment decisions with their clinicians. As someone with an autoimmune inflammatory type of arthritis myself, I know that blood work, lab tests, clinical examinations like joint exams that my rheumatologist orders provides really important information in making key treatment decisions. But I also know that some information cannot be seen in blood work and can only come from me. And so combining these different sets of information and data can help to make care delivery and disease management more complete. So why don't we start with you, Shelley? Can you tell us a little bit about yourself, who you are, what you do, and your diagnosis? How did it all happen?
My name is Shelley Fritz, and I'm a retired educator, and I'm now doing some consulting for schools, and I'm also working in a fellowship with Global Healthy Living Foundation. I'm 53 years old, and I was diagnosed with seronegative rheumatoid arthritis over 11 years ago. And I would just say that the road to finding effective treatment has not been simple for me. It's been a little bit of trial and error, especially in the beginning. It took a couple of years to even get diagnosed. I had several misdiagnoses until we connected the dots and found out it was rheumatoid arthritis. But since my diagnosis in 2012, I made the decision with my doctor to change medications many times, in fact, being on 6 biologics over the last decade. So it's been a challenge finding the best combination of medications and treatments along with my lifestyle changes to keep my disease activity down.
Thank you for sharing that with us, Shelley. And you did mention lifestyle changes. We know that RA affects everyone differently. So can you tell us a little bit about how RA has affected your life, family life, social life, work life?
Well, I'll start off by saying that fatigue is a monster. It's hard to explain fatigue to someone who hasn't had the experience of chronic fatigue. It's really different than if you, say, stay up late and you watch a late night show and then you're just kind of feeling tired the next morning. Eventually, you can boost your tiredness, with caffeine or a brisk walk. But this is really different. Fatigue is completely draining of every ounce of energy in my body. And when I'm unable to start doing something or continue doing something that needs to be done, it can cause problems, at work and at home. So it's kind of frowned upon to fall asleep in a meeting at work, right? So I felt my coworkers and my friends thought, maybe I was being lazy or uninterested, but that really wasn't the case at all. It's made me feel guilty at times for not being able to do all the things that I'd normally do when I'm feeling less fatigue. And I'd say the other way it's really impacted me is pain. It's my supervillain, pain. I haven't had a day without some level of pain since about 2009. So that was a few years before my official diagnosis of RA. And, some days the pain is very low and it's really manageable. And I rarely think about it. But some days it's radiating through my body, and I still go through my day and I push through the pain, so to speak. But on other days, it's front and center. It's all I can think about. So when I worked full time on a more rigid schedule, I had to miss work sometimes because the pain was so intense that I couldn't concentrate or move. And sometimes I went to work when I should have stayed home. And then I felt defeated, like the disease was winning, and I became paranoid that my coworkers, my friends thought that I was less of who I had been before. I just felt like a less valuable teammate, kind of a bad mom, because I couldn't physically, mentally, or socially do what I wanted to do. And I wasn't the person I had been before. So it seriously impacted my whole being. It still impacts me now, but in a whole different way. Because now I know it's not my fault, and I know that I didn't bring this upon me, and I'm not letting it take over. I'm just actively working with my RA to adapt and continue to live my life the way I want to every day without the guilt and self-deprecation.
Well, again, thank you so much for sharing that with us. It's obvious from what you're telling us that it's more than just physical. It sort of touches on every aspect of your life. And you talked a lot about pain and fatigue. And in fact, at Global Healthy Living Foundation, we conducted a study with adult US patients within our research registry, Arthritis Power. These were patients living with ankylosing spondylitis, fibromyalgia, osteoarthritis, psoriatic arthritis, lupus. And we invited patients to select up to between 3 and 10 PRO symptoms that they felt were important to track for their own disease condition. And the symptoms that rheumatology patients prioritized for tracking their disease using a smartphone app were fatigue, physical function, pain, and morning joint stiffness. And so, Shelley, you talked a lot about pain and fatigue, for example. And, I sort of understand this myself because I live with inflammatory arthritis, but it is really something your doctor can see by doing a blood test. You don't see fatigue and pain in a blood test, you don't see it on an X-ray. How then do you communicate about this pain, about how it interferes with your everyday life with your doctor? I guess I'm asking, how do you make the invisible visible?
It's been difficult at times to talk with my rheumatologist about symptoms that can't be seen with the human eye because when the blood work looked all right, the decision at my appointment, I kind of let the doctor make that decision, okay, let's continue with the treatment you're on because it seems to be working well. It looks good in your lab work. And it wasn't until I said, but wait, I have extreme pain. I can't sleep. I'm waking up in the middle of the night. And then when I wake up, I can't go back to sleep. My fatigue level and pain would be so intense that I'd miss work. So missing work became one of the pieces of criteria that my doctor and I used to kind of gauge whether my disease activity was maybe higher than we thought from the blood work. So it was sometimes hard to figure out if it was just a temporary flare or if this would keep on going and we might need to make a change in my treatment. So I ended up starting to track my pain by writing notes on a calendar. This was way back like a decade ago. And then I'm a math teacher. So I started making a line plot, that would show my pain levels and how they were fluctuating, increasing. And I took a lot of notes and tried to figure out what the triggers were that were spiking my pain. I brought that to my doctor, and my rheumatologist and I talked about it. We looked at it and looked for trends. And I think just doing that alone, the doctor knew that I was taking this very seriously and I was tracking my health. And it gave my opinions about my own health more merit. And I know it sounds strange, but if it's not showing up in the blood work, my doctor would often dismiss it as an important symptom and just tell me to get more sleep or take some Tylenol for the pain. So, a little bit after that, when Arthritis Power came out, I started using it when it was in a beta version. And it was really helpful because then I was more aware of the other factors, like tracking the fatigue and my sleep and looking at how pain was really interfering with my life. And then I brought that data to my rheumatologist, and it was just really eye-opening because it was cause for us to change medications. So we did that multiple times over the years.
That's great. Thank you very much. It could help other patients as well to understand the value of tracking symptoms. I want to come to you, Dr. Goodman, next. One of the 19th century founding fathers of modern medicine, William Osler, advised listen to your patient. He or she is telling you the diagnosis. Can you help us as a clinician to understand what PROs are and how they help you as a physician to help your patient better?
Hi, I'm delighted to be here, and I'm also delighted that Shelley explained what she's been going through because I think it really highlights what we've tried to learn over the last decade that I think differentiates us from what we thought we were learning over the decades prior to that. One of the most revealing studies was a series of interviews with patients and physicians with rheumatoid arthritis. And what we learned from that, in which the patients and the physicians ranked the symptoms that were of most importance to them in deciding how active a patient's disease were, was how little overlap there was in the two. And in fact, fatigue didn't even make it to the physician's side of the ledger at all. So many times, what we consider important and what we as physicians hang our hat on really doesn't turn out to be that relevant. Some things you can understand that we may have different needs from, like blood work. Obviously, we check for side effects and a lot of different things along that line. But when it comes to the fundamental symptoms, what a patient wants to get from treatment, we've been way off the mark. And I think the development and the evolution of patient-reported outcome measures is key. Can I say a little bit about where they come from? They don't just sort of appear as received wisdom. These are instruments that now have been developed with a real systematic approach. So I work a lot with a group called OMERACT, an outcome measures development group. And methodology that is encouraged is first do a literature review, see what's out there, what patients have already told their doctors. Secondly, talk to patients. And this is a very formal, structured data gathering exercise in which we have interviews that are structured or focus groups, but we have conversations in which we specifically focus on what is important to the patients. That then gets distilled down to a list of domains, a list of areas, factors that the patients think are important. And then there's a consensus process so that these can start with hundreds of different factors. That gets whittled down to the most important through what's called a Delphi exercise, in which there's several rounds of voting, in which you end up with a convergence. Physicians and patients respond to these. There's frequently discordance, but eventually the priorities converge. And then those factors that remain the consensus picks become the domains used for what we call a core outcome set. And those are the core outcomes that then determine what we're going to measure when we measure a patient-reported outcome. There are a couple ways that that's very important. Shelley also mentioned how many different treatments she had to go through, which I think is normal, unfortunately. I think we should also be aware how important it is to the federal agencies like the FDA and the European Medicines Group to have the results of patient-reported outcomes. They want to approve drugs that'll work for patients. So even if we had no interest, we had a great biological model, we couldn't get those drugs past the FDA without having good PRO data. So whatever we're trying to do, it's become increasingly important that we do this with patient partners.
That's great. Thank you, Dr. Goodman. It was very interesting to hear you talk about the rigor behind how these measures are developed. And in fact, you mentioned OMERACT, which I was also going to ask you about. And for our listeners who don't know, OMERACT is a global volunteer-driven, not-for-profit organization They're committed to improving outcomes for patients with autoimmune and musculoskeletal diseases through advancing the design and quality of clinical studies. Dr. Goodman, I wanted to go back to your point about listening to the patient and integrating patient-reported outcomes in various scenarios. So, interestingly enough, we did a study at Global Healthy Living Foundation with other partners, of course, on what some of the barriers to treatment optimization may be from a patient perspective and how this may impact achievement of patient goals using PROs. And I just want to say we'll provide the link to the full studies at the end of this podcast as well. But what we found was that there was a gap between rapid 3 categories and participants' own assessment of their disease activity. So again, rapid 3 for our listeners is a questionnaire that patients answer that provides their doctor information on how the patients themselves perceive their disease activity. So it asks about fatigue, pain, physical function, and so on. And in this study, interestingly, what we found was that the rapid 3 may not be very informative when setting treatment goals from a patient's perspective, exactly because of what you said. Patients may have very different goals than what's being asked in the rapid 3. For example, they may identify goals that are important to them as things like being able to ski, being able to attend a family wedding or a graduation. And so we know, Dr. Goodman, as you have repeatedly attested, that patients must be encouraged to share their treatment goals and expectations with their rheumatologist. But what are your thoughts on how patient-centered care, PROs, how these can be integrated into clinical practice? How do you envision that happening as standard of care?
So I think what Shilpa has touched on really has two questions in it, and I'm going to break it down to answer it separately. One is, what do we do with the patient-reported outcome measures in terms of daily clinical practice? And I think that's a little bit more complicated because I don't think a goal of skiing will be applicable to the vast majority of patients, but that's something that would come out in a shared decision-making process with an individual patient. So some people will have the expectation of a very high level of function. Some people's desires and needs will be more rudimentary. That'll enter into how aggressive their treatment course is, how much risk they're willing to accept in terms of achieving their treatment goals, and what they're really looking for. And that's a very individual decision made between the doctor and the patient in choosing new treatment goals. The fact that Shelley described bringing in a diary was really perfect for that because she had specific needs. I think we all kind of need not to fall asleep in the middle of a meeting at work, but I think there were a lot of other things that went into that that were very personal and would inform the decision she and her doctor made about her in particular. So I think in addition to using something that gives you, I would call it entry level data, something like the Rapid 3 that gives you a kind of big picture, you have to take that and build on it uh, for each individual patient because every person has different needs and different risk profiles. So I think there's not a one size fits all.
And that makes sense. So what you're saying is, we could use, it's important to use the standard universally applicable measures, validated measures that clinicians need to make decisions to help make decisions with their patients about their treatment, along with conversations that can help patients to articulate their own their own specific personal goals. And that's a very important point. So thank you for making that. Again, we're talking here about combining different data points, different kinds of information to provide better care. Related to that, then, Dr. Goodman, we've seen now that remote patient monitoring, or RTM, as it's called, is now reimbursable. Would you encourage patients to track their disease using PROs in real time to inform patient-centered and patient evidence-based care? So I guess the question is, would you encourage your own patients to track their disease using PROs so that when you see them in a clinical encounter, you have that information at hand as well?
I think at this point, we don't really know what to do with remote data. And I think what I heard Shelley say is that she didn't think her doctor was paying attention to the things that were important to her. And that's how she used it. And I think that was a very critical use of data tracking. The remote monitors, my concern about them as they currently exist is it's so much information that I don't know that anyone knows how to analyze it on a day-to-day basis. But I will say the other way that we use patient-reported outcomes, and I think this is the second big use for them, is in clinical trials. The fact that Shelley had to go through a series of different medications before finding help tells me a couple of things. One, we don't know what different medications address, and we clearly don't know what medications we need to give to each individual patient. So those are two huge topics. One way we use PROS is that we have to be able to demonstrate that what the majority of patients say they need are being addressed by a new medication. So that's simple. We want to be able to pool data. We want to be able to study large populations. And we have to have a framework in which to do that. And the pros provide that. The other non-patient reported area that we're also working on, and I won't go into, has to do with a lot of the personalized medicine and the real biologically driven research. So that, in a dream world, I'll be able to take tube of blood or a sample of synovial fluid and say, this is what Shelley needs, and address her treatment changes in that way.
We're in sync, Dr. Goodman, because I was just going to touch upon clinical trials, and I would love to learn more. I think all of us would love to have another podcast with you on so many of the things you've touched upon. But I want to come to clinical trials, and Shelley, I'm going to come to you very quickly. But we know that PROs can be used, as you said, outside of clinical care encounters, and they've been gaining momentum. Now play a significant role as study endpoints in the development and evaluation of new therapies. In fact, the Patient Centered Outcomes Research Institute, PCORI, urges that the outcome measures should include ones that patients prioritize and care about when developing new drugs and when testing them in trials. So, Shelley, let me give you a scenario here. So, when you're in a situation when you have to start a new medication for your RA, for example, what are some of the things that go through your mind? What do you think through as you make that decision of whether or not you want to start this new medication? And really, here I'm asking you about things like, route of administration, whether this is an injectable or a pill, but also what are the things that you consider when assessing if your medication is in fact successfully working? How do you know that your medication is working?
Well, first, if I'm able to do all the things that I need to do and want to do without symptoms interfering, then I feel like my medication is working well. And of course, it's more complicated than that, but I look at the data, and if does it show that my joint stiffness is less and my pain is less? That usually lines up with how I've been feeling, you know? Does it show that, I've been able to sleep well and without waking up in pain? If I've had a long stretch of that happening, I'll start to talk to my doctor about that. But also, it's important not to jump to conclusions, and just say, well, I've had a really bad day. I had 2 bad days. I had a bad week. It could be a flare. So it's important to kind of weigh with your doctor whether it's a flare or if it's really time to change medication. And when we do make the decision, and I say we because it is a shared decision making process between myself and my doctor, we'll I do the research on the drug that I'm considering. I'll compare side effects and other factors like how it's administered. How long, if it's an infusion, I want to know how long is the infusion, which will mean that I'll need to go to an infusion center. Will that interfere with work? How long will the infusion be? Will it be all day or will it just be for a couple of hours or 30 minutes? It makes a difference. I think through, how long I'll need to wait to actually start the new medication after it's approved and available. And another thing that I also consider is how the new medication will impact my schedule, and can I take the medication at home myself? So I kind of weigh all those things and look at the benefits of the medication and then talk about that with my doctor and then make a decision together.
That's great, Shelley. Thank you. Quick question, just as a follow up. Dr. Goodman was talking about personalized medicine as well. And I'll come back to you on that, Dr. Goodman. In fact, that's such an interesting topic that we'd love to learn more from you on that as well. But, Shelley, when you start a new medication or you switch a medication, how do you assess for yourself whether that medication is working for you? So I'm really talking about endpoints here and trying to understand if PROs can actually be used to determine what endpoints are actually important to include in clinical trials, for example. So could you share a little bit about that?
Well, as I mentioned before, it's really important, to look at trends and not jump to conclusions because when I do have a series of bad days, I have in the past automatically thought, well, nothing's working, and it's hard to see the light at the end of the tunnel. And I think I need to change medications. So, a rheumatologist once told me, it was actually my first rheumatologist. He told me that it wasn't so much that the medication that I wanted to break up with, wasn't working. It was that it wasn't working as effectively for me as it was designed to based on data from clinical trials. So it might be working at, say, 30 to 40% of effectiveness that it could potentially do for somebody else. So by tracking what's going on with me, and paying attention to my body and listening to my body, that's how I was able to look for, what was really happening over time, thinking about specific joint pain and what was causing it because there can be different reasons for having a painful thumb, for example, and it might not be my rheumatoid arthritis that's causing that pain. So it's really important to pay attention to not only how much pain you have, but where your pain is coming from and what's triggering the pain. So that's where it gets more complicated, just trying to figure out, is this really my RA that's really active? And is this a cause to change treatments? So, I talk about that with my doctor and then make a decision.
Great. And Dr. Goodman, Shelley just mentioned, she said her doctor, and we've all heard this, all of us who have some form of inflammatory arthritis have heard it from our doctors. It might not be working for you. So we have to find out what might work best for you, keeping in mind the unique person that you are. And you talked about personalized medicine. I know this is probably a very big question to ask you, but you're the right person to ask, I think. How do you envision the future of medicine with PROs and personalized medicine? What does that dialogue look like to you as we advance and make medical advances in the field as well?
So, one of the groups I'm involved with is it's an NIH consortium that addresses basic immunopathology of diseases like rheumatoid arthritis. And the hope is that by identifying inflammatory targets, much the way TNF was identified as being a driver of inflammation in RA, what we're hoping is it will identify with even more specificity what those targets are for each individual. We know, for instance, in work that we've done, that if you take PROs and identify symptoms like morning stiffness, we found that there was a difference in both the histopathology, what the joints looked like from patients with different degrees of morning stiffness, both duration and severity. And those histological biopsies were very different between people with no morning stiffness, people with long morning stiffness, people with mild morning stiffness, and people with severe morning stiffness. So there is physiology that drives the pros in a lot of situations. And right now we've got a fairly blunt tool to get at that, to really figure out what's what within our patient population. So if someone's major problem is fatigue, for instance, we could say, oh, well, we know that what you need is this drug, and that would be our priority for you. I think we'll come to that by multiple iterations of experimentation, pro development, and clinical trials. And it's a slow process, but it's been a remarkable process when you think of where we are now compared to where we were in Osler's time. And there have been a lot of advances that have been incredibly useful to our patients.
Well, that's extremely exciting and optimistic, especially, I'm sure it is for researchers and clinicians, but I think for patients particularly, and I'm now thinking also as a patient, it's so exciting to even imagine the possibility that at some point in time we'll be able to tailor treatment regimens to that specific patient and hopefully accelerate how patients can feel better, faster, and easier, I suppose. So thank you again for that. I just want to, we have a few minutes left in the podcast, and I want to talk a little bit about major conferences like, for example, the American College of Rheumatology that now has, and actually this is for the past few years, has a patient poster, patient perspective track. And I know, Shelley, you've done some work on that in that perspective track as well. What I want to ask you is for disease patients who may see their care providers once in 3 months or even once in 6 months if you're doing well enough, there's an interim period where symptoms surely come and go. They rise and fall, they ebb and flow. Can you talk a little bit about, and you did touch upon this before, but can you talk a little bit more about how tracking your disease in real time has helped you and your doctor stay on track, but has also helped the community to understand what these diseases are and how they behave? And so, why it's important for international conferences to showcase the patient perspective. And I know you've presented a poster at these in the patient perspective tracks as well.
Sure. The first poster that I worked on was on painsomnia. And painsomnia, we describe as having so much pain that you can't sleep. You have trouble getting to sleep. Once you're asleep, you wake up in pain. It's just hard to get back to sleep. So that was one of the pieces that I worked on. And now I'm focusing on using data again to track my symptoms and try to put together another poster. But when I worked on that painsomnia poster with some other patients, we really looked at the data we used my data, looked at some sleep issues that I was having over time. And we took the graphs of those and included those so that you could see the trend in how my sleep was going or how pain was interfering with my sleep, I should say. So I'm actually tracking my data now, not only for my own, benefit so that I can see how things are going and see if it matches up to how I've been feeling. But I'm also doing it because as I'm using my data, I've been trying to make a change in my life to try to change something with what I'm eating on a certain, I won't call it a diet plan, but I've just kind of made some lifestyle changes. And I want to track and see how that's going over time. And I'm hoping that, it'll be something that I could end up sharing maybe at ACR, hopefully in the future.
Wonderful, and good luck as you move into the future. I want to ask you both, we want to end on a hopeful note here, and this has been such a fascinating conversation. Dr. Goodman, I'll ask you first, and then I'll go to Shelley. What is your hope for the future in rheumatology research and rheumatology care? What is I know you might have many hopes, but can you give us one or two of your hopes for the future as we advance in this field?
I think one of the achievable hopes seems to be what we've referred to as personalized medicine, finding out through the course of detailed studies in which we correlate specific symptoms with specific mediators of disease and then can plan a specific treatment course for any given patient. I think it's an achievable hope. We're getting closer, and we have a lot of the broad basics at this point. We know a lot about patients with RA, and as Shelley has pointed out, there are different types of pain. There are different ways that pain can intrude on your life. And one of the things we have learned is that some patients have pain that's driven by inflammation and some patients don't. So while we've been giving the RA patients whose pain isn't driven by inflammation more and more anti-inflammatory therapies like TNFs, that's probably going to be a really easy, achievable goal. We can now identify these two huge separate groups of patients who aren't responding to therapy. And I think that's a key step. I think we'll be able to refine that sort of precision over time and get to the point where it's not trial and error and where we can actually select something that's going to work without going through the first 6 medications you took. I mean, we really, at this point, I also remember making rounds on patients who are being treated with aspirin and asking them how they were feeling, and if they could hear the answer, they were taking a little too much. They if they couldn't hear the answer, they were taking a little too much aspirin, and we cut back the dose by 1 and check a level. So I think the strides forward have been amazing, but boy, it just kind of makes you greedy for more precision and more accuracy in what we're doing.
That's great. And greed here is a good thing. And I like the word. I like achievable goals. And it's such a hopeful note. So thank you to you and to other researchers and clinicians who are working hard on making sure that patients like us have a better run with medications and choosing medications and making decisions. Shelley, as you know, you and I think we sort of identify with that word achievable goals. What for you, as you think about the future of your own disease, what would you hope for people living with this condition as we move into the future?
Well, of course, I hope for a cure. That would be the best thing. But meanwhile, I hope there's more research to find a cure. And I loved what Dr. Goodman said earlier about, wouldn't it be nice if we could just do a blood test, one blood test, and then be able to know what medication, what type of medication is best for this patient? I would love that. That would be so nice because I spent over a decade feeling like an experiment, just like there was just so many variables and, I just kept changing medications to try to find the right cocktail that was, a good fit for me. And so many patients are like that. Some get lucky and the first type of treatment that they try works great for them. And for others, it's kind of a hit and miss sort of thing that can last for months, years in my case. So I hope for precision medicine would be great to find, that one test that could determine whether you have RA or not and how to best treat it. The other thing that I also just want to share real quick is that I hope that doctors will continue on this trend of, I hope it's not a trend. I hope they'll continue to talk with patients about what matters to them in setting their goals, that it's not just about the lab work, it's about the quality of life that you have as a patient and what you want to be able to achieve. And, if your doctor isn't, I would just recommend to people listening, if your doctor doesn't bring this up with you, bring it up with your doctor. Because I had to change the way I talked with my new rheumatologist a bit from letting it being directed towards me to making it a conversation. And now when we talk, he'll say, it's your choice. What do you want to do? Here are the options. And we talk through it, and it's a much different conversation. So I'm hopeful that that kind of conversation happens between patients and their doctors.
What a wonderful note to end this podcast on. And yes, completely agree with you to combine different, again, we're talking about combining different pieces of information to get better care and to have better treatment, treatment regimen. You did mention blood work and blood tests. I know we've talked a little bit about this. And I'm going to bring in my colleague and co-host here, Dr. Ben Knoll, who is also going to host an episode, the next episode on blood work, actually. And so again, you know, both of you are in sync with us here. Ben Knoll is the director of patient-centered research at the Global Healthy Living Foundation and has listened closely to our fascinating conversation here. Ben, can I just bring you in for a minute here to ask you about your thoughts, what you found most interesting about this discussion, perhaps?
Thanks for the opportunity to comment on this podcast. Personally, I was really interested to hear Shelley talk about her experience as someone living with rheumatoid arthritis and seeking treatment that worked well for her. Shelley, you really went above and beyond, I think, what a lot of people do by tracking your symptoms over time. Even before Arthritis Power was available, you were keeping a journal of symptoms and changes to share that information with your doctor because that helps them know how you're doing between visits. I was also very interested in what Susan and what Dr. Goodman said about the future of patient-reported outcome measures and how powerful they can be in determining a more personalized approach to treating people living with rheumatoid arthritis or other diseases. That sounds like a very exciting area for research that needs to be done. Correlating PRO measures scores with radiographic data from x-rays and values from lab work. That would allow us to see how PROs correlate with markers of inflammation in blood and other markers of inflammation to really understand what's behind the disease activity and how patients experience it, like what's mediating the disease. So I think getting an understanding of what's happening and how PROs can be integrated into the other information that we know about people living with RA is really exciting. And I really appreciate the insights from Dr. Goodman, from Susan Goodman today, and also, of course, from Shelley. So thanks very much, Shilpa, for such an interesting discussion.
Thank you, Ben. I agree with everything you said. This has been such a fascinating conversation, and if I could, I would keep you both here forever. But thank you for sharing your insights, your struggles, Shelley, the challenges that you faced, Dr. Goodman, for explaining to us the advances that are being made in rheumatology, where we are today, where we hope to go in the future. This has been a very fascinating conversation. So thank you both very, very much. We hope you've enjoyed this episode as much as I've enjoyed hosting our two guests today of Relatable Rheumatology, where we focused on patient-reported outcomes in this episode. We all know now that living with a rheumatic disease can be a journey filled with questions, uncertainty, challenges, as we've heard from Shelley, whether it's navigating the diagnosis process, understanding treatment options, or managing symptoms. It can be difficult to find reliable information and support. And that's why we're creating this podcast to bring together real-life experiences of people living with rheumatic diseases like Shelley, with expert research evidence from experts like Dr. Goodman, challenges faced by those living with these conditions. Please remember to subscribe to our podcast so you never miss an episode, and help spread the word by rating our podcast, writing a review, and sharing us with your friends and family. We look forward to sharing more information with you during our next episode. This podcast is brought to you by GHLF and HCP Live. Thank you for listening.
This is the Global Healthy Living Foundation Podcast Network.